Good afternoon, everyone. So I'm going to give you guys a little bit of a perspective from the resident side of things, really focusing on mainly what are the key points for teaching residents and reviewing in terms of our teaching curriculum, and then what our current tools are for resident training, and then opportunities for improvement, as well as what happens next when residents go on to be fellows or go out into practice. How do they interact in the real world? So key points, I think, to take away from the consensus guidelines are really emphasizing the critical view of safety and teaching that in academic and teaching environments for residents. I think it's still very misunderstood, and a lot of residents, even now, when I ask interns or second years, what is the critical view of safety, they don't have a strong concept of exactly what that is and the three components and how to achieve those at a high level. In terms of documentation, I think this is still a new area, and clearly will take another generation for this to become common practice. But I think implementing that now in residency training and teaching residents to take their own photos, get the anterior and posterior view for that true doublet photo, is not only good for education because you can document that you've done it well and have that intraoperative pause with your team, but it also provides documentation that you're improving your skill set and seeing your technique improve as you do more lap choles as a trainee. In terms of subtotal cholecystectomy, I think that's something that as a resident you get less practice with because they don't happen that often, and when they do, it's an incredible learning opportunity. And so I think if there is a time where you have a resident who's participating in that case and you're their educator, taking the time to teach them about that, record the interaction so that you can share that with other residents in your program and review it either at your educational conference or have a special session on how to do a subtotal cholecystectomy is actually really important. I have never seen one. And so I think that's a common situation for many residents where if this is the recommendation, we need to have training on how to do it. The second point is really intraoperative cholangiogram. I think many people have made the comment on the panel that it's about interpretation of the cholangiogram, not just performing the cholangiogram. So any opportunity as a trainee to do them, I think is critical, and that at teaching institutions we probably should be doing as much cholangiography as possible so that residents are trained to go out and do it when they need to and know when they need to, as well as interpret the imaging correctly, especially if BDI is suspected. And then in the settings of acute cholecystitis or a history of acute cholecystitis or chronic inflammation, using the cholangiogram, figuring out strategies to do it appropriately and interpret that is also a key takeaway from this consensus. So current tools. I'm actually one of the resident advisory group members for the surgical curriculum on resident education, which is SCORE. SCORE is a national curriculum that's used by many residencies across the country, and it has a fantastic peer-reviewed module-based education format, and one of the modules is on lap chole. And it's a very thorough module. It was recently updated, and it actually speaks to the majority of these points, and I think is a fantastic module that honestly all residents should probably review and do as part of their curriculum. For residencies that don't use SCORE, it makes that new Safe Lap Chole didactic course through stages even more important. I've started to think about whether this should be required or not, or should it be highly encouraged. For those of you who haven't seen the new didactic course, it's fantastic as a resident. I just completed it as soon as it came out, and I think a lot of residents are starting to hear about it and taking it as well. It has great video examples. It goes through all of the bailout procedures. And I think from my perspective, it should be highly encouraged, if not required, for all residents to complete the didactic training. If you think about it, we already do things that are required that are very similar. We do FLS, we do FES. Those are required for residents to graduate from surgical residency at this point, and maybe this should be incorporated. It's such a common procedure, and it has such high consequences if a bile duct injury occurs that having that kind of consistent training for our generation of training is, I think, critical and potentially should be promoted by our organization. So what are some opportunities? How can we improve the educational environment that we have now? I think promoting the critical view of safety, using it as an educational tool, and starting to promote photo documentation or at least verbiage and teaching residents how to document verbiage appropriately in their operative report is essential. It should have three components, and it should be listed in a 3-component format so that you don't just say a critical view of safety was achieved, because we all know that there's a gray area around that. And then intraoperative cholangiography, there aren't great didactics or series of images on multiple types of cholangiograms that are in a succinct format. You can find them in multiple publications or in the didactic course, but I think having an improved image set of cholangiograms and how to interpret them, or some sort of training module that's very specific to cholangiography, would potentially be useful. And then there's also this question mark of what's the future of intraoperative ultrasound and how are we going to incorporate that into training. So I think those are going to be some areas where maybe we can work on developing additional curricula for some more focused deeper dives into cholangiography and laparoscopic ultrasound. Ultrasound is something that we don't do as part of our lap choles at my institution, and I think it's still on the horizon of training, and it will be another new technology that we have to incorporate as part of our training. I think risk stratification is another area where we could improve resident education. The Tokyo guidelines are very helpful, but I'm not sure if all residents know about those or how to use them. Even some of my co-residents haven't heard of them before, and we have a strong hepatobiliary environment at our institution. And as part of our acute care surgery service, we should probably incorporate some risk stratification curricula and strategy when we see patients that come in with acute cholecystitis, and figuring out, should this be done during this hospitalization within the first 72 hours or not, and having a conversation around that as educators. And then open cholecystectomy is becoming somewhat of a dying breed for people in my generation. If you ask residents these days how many open cholecystectomies they've done, it's probably 1 or 2, if that, and it was probably during a Whipple. It's becoming a rarer experience for people of my generation, and I think finding opportunities to make sure that we can teach that or incorporate it as part of another procedure is really critical, because if you do, as your algorithm, if you go out into general surgery practice and you're in the community, as part of your algorithm, your option is converting to open, you need to be able to do that and do it safely. And if you can't, then you need to know that that's your limitation as an individual and that you should probably consider transfer. So lastly, when you go out into practice, the reason for all of this and the trainee perspective is when we eventually go out, we need to be prepared for the new future technology, all of these things that are changing, and making sure that our documentation is reflective of these guidelines, as well as teaching residents how to use adjuncts, how to use these exit or bailout strategies, what should be your individual algorithm the first couple of years out in practice, and how can you develop that from there? Because initially, your confidence may not be as high. You don't have that experience yet, and being incredibly safe during the first few years out in practice is essential to your career and to the safety of your patients. And so really teaching these adjuncts or exit bailout strategies, I think, is the crux of resident training, and the SAGE's didactic courses do go over those, and I think is a fantastic stepping stone for getting more education on this for residents. And one other thing that I would like to speak to is that we have a culture in surgery of feeling like we need to finish the operation, that you're a surgeon, you should be able to finish it, you should be able to get the gallbladder out. And maybe we need to change that culture and normalize seeking help, and normalize for residents that sometimes you might not be able to do it, and that's actually okay. It's better for your patient. Our group recently did a study that's going to be published pretty soon that actually interviewed patients who had had a lap chole and asked them through a number of scenarios, if a bile duct injury occurred, would you want them to be transferred? Or if the surgeon was uncomfortable or not sure if there was an injury or that there could be some concerning anatomy and initiated your transfer to another institution, how would you feel about that? And unanimously, patients are satisfied with that. They would go back and see that surgeon again. They trust you even more because you made a decision to transfer a patient for appropriate reasons, for their safety. And I think that that's something that most surgeons are shy about or are not sure if that's the right move to do. So we really need to change that culture of teaching residents, teaching our colleagues that it's okay to get help, it's okay to make that call or transfer the patient's care if necessary. So all of this to say, I think focusing on taking these guidelines and really taking them back to our educational institutions and focus on training the next generation of surgeons is how we're going to implement these new trends. I'd be happy to take any questions and appreciate your attention.